Welcome to Health and Family. I'm Shay Burgess, and with me in studio today, our Chief Medical Officer, Dr. Cheryl Peakball, and Assessment Officer, Ms. Dy-Jaun DeRosa. Our topic today is a recently published Health in Review. We thank you both for being here. Health in Review is a collection of data that compares Bermuda with other developed countries around the world. It was last published in 2011. Today we'll talk about how Bermuda is doing when compared to other developed jurisdictions around the world. Some of the statistics are encouraging and some are sobering, and we'll talk about what we are doing well and what needs to improve. For example, we're doing well at reducing daily smoking. Just 10% of the population smokes daily. This is one of the lowest of all countries tested. We welcome both of you to Health and Family. Dr. Peakball, we're going to start with you, and if you could just sort of expand to us about the Health in Review and why it's so important.
Sure. Health in Review's subtitle is International Comparative Analysis of Bermuda Health System Indicators, which is a mouthful. It sounds quite technical, but really all it means is that we have compared Bermuda's health system and the health of the people of Bermuda with other similarly developed countries. And it's important because the comparison itself helps us to gauge where we are. It also allows us to look at the trends over time. And most importantly, it is part of the continuing conversation around what we can do to improve the health of the community and how we can improve trends. So it really informs our discussions and allows us to create healthy policies and to take intervention on areas that we're not doing so well in. The document is full of data and statistics, and it is quite of interest to those people who are providers, who are delivering health services, and also those who are receiving those health services on an academic level. But the real value of it is that it allows us to see how we're doing in comparison to other countries that are similar to us. The comparisons are not to be taken absolutely. It is an indication, but it allows us to identify areas that we need to improve on and areas that we are doing well in, and to pat ourselves on the back and to continue in those efforts. It looks at multiple indicators or measures of health system strength as well as individual health.
Okay. So I wanted us to start with the health status. Yes. And what types of information is being looked at through that?
In health status, there are a number of indicators of population health. In particular, one of the measures is life expectancy. So clearly, how long a population lives is an indication for how healthy they are. And Health in Review looks at life expectancy both at birth, how long you're expected to live from birth in that population, and life expectancy at age 65, which is a measure of how well our health system is as we age and become more vulnerable. So that is one key measure of population health. Another, of course, is mortality rates, what we're dying of, and morbidity rates, what we're getting sick from. So the document gives just a number of specific measures of those areas that we are dying from and getting sick from, and allows us to see where we have problems and where we need to make some changes to the health system or make some changes to our own individual behavior.
So, Ms. DeRosa, thank you for that. Yeah. I wanted to just to touch on that, the life expectancy, what is that for Bermuda? Is it around?
Well, it's approaching 85 for women.
Wow.
And 77, I think, for men. So it compares quite well with the other countries of the OECD. And I forgot to mention that the comparison that is being made is with 35 particular countries that are members of the OECD, the Organization for Economic Cooperation and Development. So the OECD has many similarities to Bermuda, those countries' social and economic factors in Bermuda. And it also included, I believe, 9 countries that are of interest to us, as well as 9 partner countries, they're called, and 21 countries that are in the Caribbean. So it is a very broad comparison, and it allows us to just see where we stack up.
Okay, interesting stuff. So, Ms. DeRosa, as far as Bermuda, how are we doing stacked up to the other countries, and what improvements have been made over the years? If you could talk to us about that.
Sure. Well, of course, there's always going to be the good, the bad, and the okay. Let's start with what we're doing really well. Dr. Peakball measured our key measures of population health, which are increases in life expectancy, and we're also showing declines in all of our death rates, which means that we're not dying as fast as people are dying in other countries. So that means that overall, we're doing quite well. When we look at what we're dying of, that's when we see the mixed picture. Okay. So surprisingly, our overall cancer rates and our cancer deaths and our by cancer site are on par with the OECD countries, especially for lung cancer, colorectal cancer, breast cancer, and cervical cancer. So that's kind of an okay. Also our cardiovascular disease or circulatory diseases, heart diseases, and stroke, they're also okay. And communicable diseases are okay, but our AIDS prevalence is among the lowest of the OECD countries. And I think that's a testament to the care that's provided in our community for persons living with HIV and AIDS. Where we're doing better, much better than the OECD, is our suicide rates. Our infant mortality rates are very low. So an infant mortality is any death that occurs in the first year of life, and our maternal mortality, and that's any death that occurs during pregnancy or soon after pregnancy. And we have had 0 deaths due to that within, I think maybe 1 in the last 10 years, but these are both exceptional figures here.
Great news.
Yeah.
Great news.
So now we'll go to where we're not doing so
Okay.
great. Any guesses? Well, I'm sure you can figure out that diabetes is one of the ones where we're not doing so great. And of course, that's related to our high prevalence of diabetes as well. We do have one of the highest prevalence rates of all of the OECD countries. We're third only to Turkey and to Mexico. And then our prostate cancer mortality is also quite high in comparison to the OECD countries. But these deaths are generally occurring among men of advanced age that may also have other health conditions that contribute to their death. So it should be taken with some caution and looked at in context as opposed to just an absolute figure, and this is the be-all and end-all of it. Okay. And then again, the homicides, murders, and transport accidents, those are other areas where we're just not doing so great, and everyone's aware of that as well.
Yeah, tells us that, yeah.
Yes. So the homicides, murders, and transport accidents are considered external causes of death. And there are differences in gender. We already mentioned that life expectancy has differences in gender, with men having a lower life expectancy than women, and it's partly because they are more likely to die of these external causes of the transport accidents and the murders. For all external causes combined, because external causes also includes drowning, it includes falls, it also includes overdoses, the males are on par, but the females are the lowest of all OECD countries.
All right,
so
good job.
Go women.
All right, ladies.
For homicides and murders, females are on par or close to the OECD average, but the male rate is 6 times higher than the OECD average. So that's something that we really need to look at. Suicide, the lowest for both genders. Transport accidents, again, females, the lowest of all the OECD countries.
Of course.
And males among the highest. And then the overall injury rates injury rates due to collisions are higher than all of the OECD countries. So
amongst the men.
Overall.
Oh, really?
Yeah, that's one that we did not break down by gender. It just looks at how many traffic collisions we had that resulted in an injury.
Okay. So back to you, Dr. Ball. So the risk factors and related conditions, what does this section talk to us about specifically, if you could delve into that?
Yes, and if I may, I just wanted to say one thing about the information. As you can see, there's a copious amount of statistics and data, of which this is just the tip of the iceberg. And the reality is that a lot of this is not new to us. We live in Bermuda, we know the stories, and so this is the information that has been gathered both through the survey in 2014 of chronic disease risk factors and the more recent data that comes from the hospital that is used for this analysis has reinforced what we already know about our community and I think validated some of our assumptions with actual information. So risk factors are important because they actually give us a picture of the future. As we know, risk factors of today are the diseases of tomorrow. That's my favorite saying because it is so clear and so true. That is, things like our weight, being overweight or obese, a significant risk factor, and as we know, it is perhaps underlying many of our other chronic diseases, including cancer and, of course, heart disease and diabetes. Those risk factors are important because they can be changed. There's something we can do about them. Not all of them. Some we can't do anything about, like our family history or our gender. But there are modifiable risk factors like our weight, as well as our habits, our behaviors. So how we're eating, whether we're eating fresh fruits and vegetables, or whether we are consuming too much alcohol or smoking cigarettes. So these risk factors give us the ability to make a difference in these figures in the future and also in our individual lives. And we want to focus on them. In fact, that is a big part of the reason we do this at all, make these comparisons, because there is something we can do about it.
All right. Well, we're going to take a break and we'll be right back with more of this Health in Review. And we welcome you back. I'm talking today to Chief Medical Officer Dr. Cheryl Peak-Ball and Assessment Officer Ms. Dy-Jaun DeRosa about Health in Review, which looks at how we compare to other jurisdictions in terms of our health and our health care system. Welcome back, ladies. So we were talking before the break about the risk factors. So if you can continue on and expand on that, we'd appreciate that.
Sure. Dr. Peak-Ball already mentioned our overweight and obesity prevalence is quite high. I am going to put a plug in here for the STEP survey 2019 because this is the only way that we can really collect this data. And we want to have the most accurate data, so we will need to go and find you, or you can come to us and we can do your measured height and weight so that we can have accurate data on what our obesity is. And hopefully lots of you have made some changes and that number can come down. So we also looked at fruit and vegetable consumption and physical activity. And the indicator used, or the measure used for fruit and vegetable, was just 1 serving per day. So are you having 1 fruit or 1 vegetable at any point during your day? And you know that that's not exactly the recommended. You're supposed to have at least 5. So if we're looking at just 1, then we are on par or even better than the OECD countries. But once we looked at if you're having 3 per day, it's less than 20% of us are having 3 or more fruits and vegetables per day. So we have to take into account what the measure is and what the measure means. And our physical activity, yes, we're doing quite well in terms of physical activity, but the measure is 150 minutes of moderate physical activity per week. So 30 minutes per day for at least 5 days a week. If that's moderate physical activity, then that may not make that much difference with your BMI. If it's intense physical activity, then it might make more of a difference. But it's just saying that we're at the level where we can maintain, but we want to get to the level where we can reduce our BMIs as a population.
Okay, so sticking with you, I wanted to look at how Bermuda compares to the rest of the Caribbean countries, if you could expand on that for us.
Absolutely. Bermuda actually compares exceptionally well to other countries in the Caribbean. And this is probably partly because of our overall gross domestic product, our standards of living, those sorts of things. Our life expectancy, we already mentioned, was 85, and that's significantly better than all of the Caribbean countries that were looked at, the 21, and our all-cause mortality rate. And again, our infant mortality is less as well. The only areas where we are worse than the averages for the Caribbean are, surprisingly, lung cancer mortality, and not surprisingly, transport accident mortality among males. And for the other ones, surprisingly, we're on par, mostly on par. We only fare better for our communicable and our overall non-communicable disease mortality. We fare better for our diabetes mortality,
Really?
which surprised me. But when we look at the types of foods that we're eating throughout the Caribbean, we can make some assumptions there. Our cerebrovascular disease mortality and our breast cancer mortality is better than the Caribbean as well. For the Caribbean, comparison to the Caribbean countries, we also looked at immunization coverage. And these looks at, we don't have cases of polio, diphtheria, tetanus, pertussis, measles, mumps, rubella, and our immunization coverage is on par with the Caribbean countries.
Okay,
So that's good.
So, Dr. Peekball, I wanted us to look at the indicators used for the healthcare utilization. How are we doing with that?
Yes, well, first, we're talking so far a lot about mortality, and I would like to just point out that mortality is a fairly crude measure of our health system quality. We don't want to die and be counted as a number for mortality. We really want to look at well before that in the disease progression, how many people are becoming ill. And so hospitalization rates is one indicator of healthcare utilization and quality. We are looking with that at how often people are unable to care for themselves in their communities with their disease in the primary healthcare sector. And how often they're ending up in hospital for those problems that could have been prevented if there were a more ideal community healthcare sector. Hospitalization rate is very important, therefore. And it's also important to look at the length of stay once you get in the hospital, how quickly your problem is managed and you're able to be back at home. So those are two of the important indicators under healthcare utilization. And Bermuda certainly you wouldn't be surprised to know that our length of stay is higher than the average of the OECD countries. And part of that has to do with the fact that we are not necessarily capable to handle discharges in the community because of the limited outpatient facilities and rest home facilities. So that length of stay, although we are looking at the hospital's number, it does reflect the community's ability to have safe places for people to be discharged to. But those are two very important utilization figures that were looked at in this study. I think it's also important to indicate that there are ways in which we know we've improved. Bermuda was lower in OECD hospitalizations for many diseases like cancer as well as COPD, chronic obstructive pulmonary disease, and hypertension. And our 30-day in-hospital mortality was lower than OECD, and that is good. That is for things like acute MI, myocardial infarction, or heart attack. Bermuda, however, remains higher than the OECD countries in important areas like the length of stay, as I mentioned, as well as hospitalization for asthma, which we know is a very important and very prevalent chronic disease in Bermuda, as well as some of our diabetes complications like major amputation of the lower limb.
If we could just stay with you for a second in regards to hospitalization, because in other countries, I'm thinking of our neighbors, our immediate neighbors, a lot of the times they don't keep people in the hospital, for example, giving birth. I mean,
Yes.
they'll discharge you next day maybe. In Bermuda, it's certainly different.
Length of stay is impacted by a lot of things, and so in terms of comparing them, we have to be careful, and a lot of this information will have to be dissected and compared fairly, so we're comparing apples with apples and oranges with oranges. Length of stay has a lot to do with the kinds of services that are available in the outpatient setting, so that you don't get to the hospital in such bad shape, or you don't go at all and you don't stay long once you're in the hospital, is a reflection of the hospital's quality of care, as well as their procedures, as you mentioned with pregnancy, getting in and out at a certain length of stay varies from countries to country. So these comparisons, I think my point is that these comparisons are worth investigating more closely and having conversations amongst healthcare providers and the system stakeholders to figure out what all this information means, because you can sometimes make unfair comparisons or draw inaccurate conclusions from the raw information. But the raw information is a very important starting point, and I think that's why we're pleased that Health in Review has been completed for 2017, in that it allows us to take a kind of milestone touched point at our health system and continue the conversation with that added information.
Okay, good. I was just wondering why it's such a discrepancy as far as, person A has a baby and person B, and then both in the same health condition and whatnot, and one goes home maybe the next day and one stays maybe 2 or 3 days. Is it just to save on cost or whatnot, or?
In different jurisdictions and even in different community settings in large jurisdictions, there are variations in what the protocols are within a hospital setting with regard to discharge, and also the support services, because discharge has to be supported by community services and home services that are able to continue the care that has to end in the hospital. So it's one of those measures that you have to compare very carefully with other jurisdictions, because it's impacted by a lot of other factors.
Yes. Yeah, once you said that, it makes sense. Yeah. Alrighty, Ms. DeRosa, I wanted to talk to us, if you could go over again about how Bermuda compares with the other OECD countries.
Sure, and Dr. Peakball did mention quite a bit of the relative comparisons, so I'm just going to touch on a few that weren't mentioned. But there was the talk of the hospital discharges and the average length of stay. So even though they are relatively high, there have been declines over the past 10 years. So there is some progress there. And I just want to talk about why people are going into hospital, because that's a benchmark of what's happening in the community. So no surprise that women are mostly in hospital for pregnancy. And then for men, they are mostly in hospital for external causes, so injuries, poisonings, that sorts of things.
Poisonings?
Yes, overdoses, that sort of thing. Yes, it's a broad category. Okay. So, but it's mainly injuries.
Alcohol would be in
yes,
there.
Alcohol would be in there. We also did notice that we had quite a few persons going in for use of marijuana, because there can be some side effects to marijuana as well, and other drugs. The next three would be circulatory diseases, diseases of the digestive system, and respiratory system diseases such as asthma, which was also mentioned. Talking about the longest lengths of stay, and again, this is related to our whole system, mental and behavioral disorders tend to have a longer length of stay, and diseases of the nervous system. So these are things like dementia, Alzheimer's. A person can be in hospital for many years with Parkinson's disease or something like that, just because there is no other place in the community for them. So those are the types of things that we can also look at. We looked at surgical procedures and medical technologies. So the ones that OECD suggested we look at was the rate of cesarean sections and our rate of cataract surgeries, and we're on par with OECD for those. Cataract surgeries was also looked at as it's one of those surgeries that used to have been done mainly in hospital, and now 99% of them are done in an outpatient setting, and that's progress as well. We do have higher use of CT scans and MRIs, so that's something that we would need to look at. Our hospital beds, our total number of beds and the number of beds used for curative services are on par with the OECD average, but our number of long-term care beds, so again, this relates to our population over 65, is higher than the OECD average, and again, that's related to perhaps the need for more beds of a certain level within the community.
And wouldn't that depend on, so Bermuda is a relatively small country, and your other countries are big, and I'm sure may have 2 or 3 hospitals, and then the bed
size and the level of care that is available. So there are various levels of care in long-term care facilities. Some require skilled nursing, others just require what's the type, respite care or assisted living. Yeah. So just different levels of care required for persons of advanced age. Okay. Not that 65 is old.
No, it isn't, not today.
But yeah. And then we also looked at our health workforce. So do we have enough physicians or dentists or psychiatrists within the population? Now, there is no set standard for this, and we are working with the Pan American Health Organization to determine what Bermuda needs in these areas. But although we tend to be on par with the OECD average, the number of nurses, pharmacists, and physiotherapists are slightly below the OECD average, while the number of GPs and obstetricians per 1,000 live births are slightly higher than the OECD average. So those are some things that we need to look at as well. And health expenditure, which I'm sure Dr. Peakball will touch on a bit later. Our health expenditure per person and by share of our GDP is much higher than the OECD average.
Okay, well, this is a good time to say anything. So look at that.
Dy-Jaun has said it very well. I don't have a lot else to say on those particular points, but I think what this discussion does raise is that there is a tremendous need for further discussion of all of this information. We've already talked about the fact that the comparison has to be made very carefully, and we're looking forward in the weeks ahead to talking with specific healthcare providers in different specialties and in different parts of the health system to really understand more deeply the meaning of all of this information and to be able to then make right adjustments to the health system. With regard to expenditure, I think that is the area where the most improvement can be made. As we said out the top, our mortality figures, for instance, measure quite well against the rest of the world. But where we start to see a need for improvement is in how what our lives are and our well-being in between birth and death. And it is in those areas that we can improve, but also improve the value of the health care that we receive. So for the fact that our expenditure per person parity is twice the OECD average means that we're paying a lot more for the same kind of health care. So we're getting good results in many instances, particularly in instances related to some of the chronic diseases, and infant and maternal mortality are also examples, but we are not getting good value for money, it appears. And so it will be in that vein that we figure out how can we keep these good results or make some of them even better for a more reasonable cost. That, I think, is the challenge of the coming decade. And so that is the way in which we'll use this information to figure out more specifically how to improve our primary healthcare services, how to prevent people from getting sick, how to reduce risk factors so that we are not having the volume and the burden of illness in the community. We're not having the morbidity, which leads to mortality prematurely. So those are the kinds of further discussions we're looking forward to. The information is one thing, but then we have to really take meaning from that and take some meaningful action based on it and based on our discussions with each other. So we're looking forward to having lots more discussions within the health sector. And in fact, currently, speaking of plugs, there is the symposium around reducing the rise in diabetes and obesity. It has a catchier name, Halting the Rise of Obesity and Diabetes Symposium, and that is about using this information and having a multi-sectoral approach to improving our health and getting more value for money in the health system.
Okay, well, unfortunately, our time's almost over, so we'll just say any final remarks to you, Ms. DeRosa, as to this whole health in review. This is really, really interesting to me to see how we compare with other countries. If you could just, as we close up.
Sure, I would just piggyback on what Dr. Peakball has said. We are embarking on our national strategy for obesity and diabetes, and the risk factors for obesity are also risk factors for cancer and other chronic diseases. So this needs to be a full community discussion. You can't say that, you have to take personal responsibility, and I would advise that just go on and find the report. It's at health.gov.bm/reports. Look for Health in Review 2017 second edition. And you can pick out the sections that can relate to you as an individual as well. And it's quite clear. You can see the graphs to show you where we are comparing. So, and also, get involved and see what we can do to improve our own health system. Take personal responsibility for your health.
Okay, well, I was talking to my boss a few minutes ago and telling her we've certainly done a lot of programs on this topic, which needs to be done. I agree with that. So hopefully we'll be making a difference somewhere. Thank you so much. Anything else before we go?
No, just thanks for the opportunity to let people know the information is out there and it's really up to them. So thank you.
All right. Thank
Yeah.
you both, Ms. DeRosa and Dr. Peekball. Today we've been talking about how we stack up in terms of health against other developed countries around the world. I'd like to thank government's Chief Medical Officer and the Assessment Officer for coming to the studio today. Until next time, I'm Shay Burgess. Thanks for watching Health and Family.